Hello again, everybody. Welcome to case study number 13. This will be a patient coming in with pain while urinating. If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or on the I button on the upper right hand corner. For some reason, some people have had difficulty clicking on the link in the description. The I button should get you there. I really appreciate all the contributions I can get, and I thank those of you who have already subscribed. But $1 a month really goes a long way to help keep these videos free and offset the costs that it takes to make these videos. So thank you very much in advance for your consideration. All right, so we've got an 18-year-old white woman coming into the clinic complaining of pain with urination for the last 3 days. She says that this has been accompanied by an increase urge to urinate about 8 times per day she's going to the bathroom, though she says she doesn't pee as much when she does go, and she's not drinking any more fluids than usual. She denies fever, chills, nausea, vomiting, back pain, and vaginal discharge. There's no pain except for when she urinates. She is a freshman in college and does not work. She's sexually monogamous with her boyfriend and uses protection. She drinks socially on the weekend, doesn't smoke, and endorses cannabis use 2 times per month. Her most recent period was 3 weeks ago, and her cycles are regular. No significant past medical history, she's on no medications, and vitals are within normal limits. So what are we going to do by way of physical exam for this patient? Right, so we can be fairly comprehensive. The big thing here is that we want to do a genital exam. It's not the most important thing, but the fact of the matter is that one of the things that can cause dysuria or just genital pain in general is vaginitis. So it is one of the things that we're going to do. Oftentimes it gets neglected. So what we find is that pretty much everything is normal and her genital exam is normal as well. So this patient has dysuria. Now, what does dysuria mean? It just means pain, discomfort while urinating, and that's all she's got. All right, so what is our differential? Well, urethritis, cystitis, and pyelonephritis. All of those are going to cause dysuria. And for the most part, they're going to be isolated dysuria with the exception of pyelonephritis, which often is accompanied by fever and flank pain. Okay, now nephrolithiasis is another possibility, tends to occur in younger people, and then malignancy is a remote possibility. Then there are some sex-specific causes. Cervicitis, ectopic pregnancy, ovarian torsion, pelvic inflammatory disease in a female. In a male, we might think of something like prostatitis or balanitis. Okay, so what are we going to do for our workup? The big thing here is that we want to look at the urine. She's got dysuria, so the urine is going to give us some hints. Because she is a woman of reproductive age, we want to make sure that she's not pregnant. Now, pregnancy is not going to cause dysuria, at least at the very beginning. However, as we're going to see, because this patient may have a UTI, we want to know if she's pregnant because that is going to influence how we treat her. We also want to check for STD. Chlamydia and gonorrhea can cause dysuria. It's specifically going to cause urethritis. And she is a younger woman and she's having sex. So that's something that we always want to do, even though she says she's using protection. And what do we find? So the urinalysis shows positive nitrates and esterase. There's also some blood in the urine. So she's got positive red blood cells, positive white blood cells, and bacteria that we're seeing under microscopy. The culture with sensitivity is pending pretty much always on CCS. If you get a culture, it's going to be pending, but you want to make sure that you order that. Her pregnancy test was negative, and the chlamydia and gonorrhea NAAT were both negative. So our diagnosis here is acute cystitis. Specifically, this is uncomplicated acute cystitis. You see this all the time in the ED. It is super duper common. And you probably surmised this already. So the treatment is going to be oral antibiotics, given this is uncomplicated. And you can use nitrofurantoin or trimethoprim sulfamethoxazole as long as it's uncomplicated. Now, if she were pregnant, what would we avoid? We would avoid Bactrim, trimethoprim sulfamethoxazole. Remember that this inhibits folate synthesis, and so you would run the risk of a neural tube defect if she were in fact pregnant. So in that case, you would either use amoxicillin or amoxicillin clavulanate, or you could just go with nitrofurantoin. The thing with nitrofurantoin is that you can't always use it in pregnancy. You don't want to use it in the third trimester because there's a risk of hemolysis. So safest to go with amoxicillin in a pregnant patient. And this patient's going to be managed outpatient. So UTI, specifically cystitis, is the most common bacterial infection in the U.S. It accounts for more than 10 million visits per year. And it most commonly presents with pain with urination or dysuria, which is typically going to be associated with urinary urgency. They have to go, they gotta go now. And urinary frequency, meaning they gotta go more often than usual, even if they're not peeing as much when they go. The number one microbial cause is E. coli. However, there are other causes as well. Klebsiella comes to mind first. There are some common risk factors. Frequent sexual intercourse can do it. History of UTI, and some women just get this and they get it a lot, and a lot of times they'll come in and they'll say, "Doc, I have a bladder infection," and they know it. Pregnancy can raise the risk as well. And then in males, uncircumcised penis can raise your risk. Another thing is unprotected anal intercourse. Naturally, there's feces there that's got E. coli, and so it can be introduced into the urethra. The thing with males, though, is you're unlikely to get a bladder infection because the male urethra is much longer than the female urethra. The female urethra is roughly is as long as your pinky finger. In males, it's that length plus the length of the penis, so it's a lot more difficult for bacteria to make it all the way to the bladder. You've got good amounts of antibodies that exist naturally within the urethra. The treatment, of course, as mentioned, is antibiotics. So most cases of cystitis are uncomplicated. However, there are a number of causes or a number of risk factors or indicators that would make the case complicated, as you can see here. Patients who have complicated cystitis and systemic signs, specifically fever, should be admitted and treated with either a fluoroquinolone or nitrofurantoin. You may admit these patients and give them IV antibiotics. Specifically, you could give them ampicillin, gentamicin, or ceftriaxone if there are systemic features present. So what that means is that you can have cystitis and systemic signs. It doesn't necessarily make it pyelonephritis, and we'll get to that when we talk about our differentials. In pregnant patients, you typically treat these patients in the same way, nitrofurantoin, but you avoid Bactrim and fluoroquinolones because of the teratogenic effects of those drugs. Common differentials, urethritis. Remember, this is typically an STD, either non-gonococcal or gonococcal. This is going to be differentiated based on that NAAT. Make sure that you rule that out because chlamydia and gonorrhea are treated differently. Pyelonephritis, you'll typically see a fever, flank pain, so you tap sort of under their rib cage on the back and you will be able to appreciate some pain. A lot of times they'll have nausea and vomiting. Remember that because this is a kidney infection, you'll often see white blood cell casts. Make sure if you suspect pyelonephritis that you're also getting a CBC and blood cultures. We did not suspect that in this patient because she did not have any of those features. Nephrolithiasis, kidney stones, is typically colicky pain and it radiates to the groin. This can happen in males and females alike. You will see hematuria, but it might be a little bit more gross than what you would see in cystitis. A lot of times these patients also will have a personal history. People who get this tend to get it frequently. Malignancy, not something we're really thinking about in this patient, has typically a normal presentation. Usually these patients are older and it will fail treatment. Sex-specific causes, cervicitis, STD. Vaginitis, look for vaginal pruritus and discharge. Ectopic pregnancy, look for a positive pregnancy test. And you would follow that up with ultrasound. You would see no pregnancy in the uterus, but you would see some sort of mass in a fallopian tube typically. Ovarian torsion, very, very severe pain. You would not see any abnormalities on urinalysis. Pelvic inflammatory disease, look for a history of STD that was not treated. And then in males, prostatitis and balanitis, we're not going to go into that because this is not a male patient. So to recap, cystitis is the most common cause of dysuria in a young woman. The major differentials are urethritis and pyelonephritis. Basic orders are going to be your UA, NAAT, and a pregnancy test. Make sure and get that pregnancy test because it will influence your management. The management is antibiotics, either nitrofurantoin or Bactrim. Complicated cases are treated somewhat differently. If the patient is not pregnant and they got systemic signs, you should admit them and use either a fluoroquinolone or ceftriaxone. Ceftriaxone is probably safest because you can administer it to a pregnant or non-pregnant patient. If the patient is pregnant, then you're going to go with nitrofurantoin or ceftriaxone, easily given IV. And if they've got systemic features, then you will admit them and use IV antibiotics, namely ceftriaxone. If they're pregnant and they don't have systemic signs, you can just give them PO ceftriaxone. If they need IV antibiotics, ceftriaxone is something that can be given IV. Complications include pyelonephritis, basically an ascending infection if they're not treated. Preterm delivery if they are currently pregnant. So we want to make sure and we get out in front of this right away.